Welcome to Clear on Health.
TSTV, connecting your world.
Good evening, viewers. Welcome to our program Clear on Health on African Health Television on TSTV. My name is Dr. Fumilayo Elusoji, and I'll be your anchor and your host today on the program. With me in the studio is Dr. Usiju Nglari. He's an anesthetic doctor. Thank you so much, sir, for joining us today.
Thank you. You're welcome.
Yes. So far we've been talking about certain things related to the woman. We talked about antenatal care, we talked about normal delivery, we went on to talk about difficult deliveries, and then we talked about postnatal periods. Today we would like to talk about anesthesia and delivery. Now there are certain things about anesthesia that we want the general public to know. Now the use of anesthesia dates back to, a long time ago. Ancient Egyptians, ancient, Babylonians, Assyrians, they had different things they used to reduce pain. Now, anesthesia simply means without sensation. It was coined from a Greek word, by someone to mean without sensation. So, sir, what is the history of anesthesia in obstetrics? I know it has a very rich history, and then I'll just like people to know, what it is about.
Thank you very much.
Yes,
You're
sir.
welcome. Basically, I think we need to differentiate anesthesia and analgesia first.
Yes.
Analgesia can be like relieving pain. Then anesthesia got to do with total abolishing pain, whether associated with loss of consciousness or still maintaining consciousness.
Yes.
So that's basically the two differences. Yeah. So then when it comes to obstetric analgesia or anesthesia, I think it's dated back to as long as 1847. I think it started with a physician, a Scottish physician who is by name James Simpson. So he was the first person that brought the idea, but people could not accept because of fear.
Yeah.
So totally people had to avoid him until around 10 years after. That was when a physician, English physician by name John Snow, I think he now was able to convince olden day Queen Victoria. She now agreed to undergo, to have analgesia for labor, of which she had it.
Yeah.
So it was thereafter, which was like a breakthrough. It was a Nobel something. Then people had to accept, and now started accepting. That was it. So that's how it came down. Then until around 1960s, because it was one thing leading to the other. After that, I think opioid was introduced. Drugs like common drugs that we know, petidine, a shot of petidine in labor could relieve the pain. It may not abolish totally, but it could relieve it.
The pain,
In low research settings, drugs like, just a shot of morphine or a shot of pentazocine, all those common opioids could help in labor. Then I think after that, nitrous oxide came in, which is commonly known as laughing gas. So you give it under with the first mask. Likewise, ether. Patient will keep on sniffing. Before you know, it relieves and patient will just sleep off. It has both analgesic and sedative effect. So patient will sleep off. So it is more or less like patient-controlled analgesia. You inhale. When the pain abolishes a bit, patient may even sleep off. Then by the time it wears off, then patient wakes up. So it's a continuous process until. So that was it. So likewise, ether. Ether was an olden day anesthetic agent. There is something we call an anesthesia machine vaporizer. Vaporizer, it's a liquid form. You add into the vaporizer. The vaporizer will now heat it. So oxygen is the carrier gas that pushes. So as you keep inhaling. So one thing leading to other, progress from one stage to the other. until around early 1990s. That's to 1900 down to 1960. That was when epidural now came in. Epidural spinal anesthesia. So, which is applicable to both labor analgesia and labor anesthesia.
Okay.
So that's a brief history of
anesthesia so
anesthesia
far.
So far we have gone.
We've come a long way, very long way.
Yes.
So, how far have we come? Let's streamline it to Nigeria, because you know the world is, new things are invented every day. The world is changing.
Really, the world is a global place. However, in context to our country, that's where we practice. I still believe we are far, far, far. The knowledge of anesthesia and analgesia is still, so that's it. But I think we need to still educate people. Gradually, people get to know about it. But when it comes to Nigerian context, as far as analgesia is concerned, I think there are so many factors that is hindering the progress in that aspect.
Yeah.
Economically, then the knowledge too. What I mean by knowledge is the number one. So many people don't have much information about anesthesia. Thank God now for the world is a global internet. Any patient, most educated patients going for anesthesia, they must have gone through really around anesthesia, though they may not comprehend exactly, but at least they have some minimal knowledge about it. Then in the aspect of scale of 1 to 10, I think, as I've said earlier, that the economical aspect in the bigger cities, if some people are told that, okay, we give you epidural anesthesia, analgesia, monitoring in labor, probably it might be of a significant cost. Some, because of the economic complication, they may tell you they will keep that money to continue life with it. So I think is one factor. Then the number two, as I said earlier, is the knowledge. People don't have much knowledge about it.
Yes.
Yeah. Then number three, some people are scared that there is, I don't know where they got the information, but they will tell you they may experience severe back pain at the end.
Yeah.
So all those ones, I think they have explanation to it. Because I don't know, maybe in our subsequent questions, we may get there when we are describing the procedure itself. But unless when there is complication, otherwise, we don't envisage history of back pain, somebody will get paralyzed, all those ones. Because we are not getting to any nerve that will kind of paralyze a patient or whatever.
Yes.
So in a simpler term. So I think it all rounds around the knowledge. People don't have much knowledge. So we have a great task because we have to keep educating our people. Gradually, as we keep going, we get to it. We'll get to the stage one day.
Yes. Thank you so
but
much.
But at the scale of 1 to 10, I still believe we are less than 5. Far
less than
1.
But still back.
Far backward.
And that means we can do better.
Yeah, because I know in the whole, some hospitals where we practice, women, you may find 3, 4, 5 women delivering in a day, but hardly one may request for epidural. Okay. Yeah, so the whole day it means nothing happened. So that's the reason why I'm saying from that context that we are still far behind.
Far behind.
Yes, ma'am.
So delivery can be painless.
It's possible.
So I want people to know that delivery can be painless. You can have a painless delivery, and there's provision for that.
So much, very readily available.
Very readily available. Thank you so much, sir, for that explanation. So we'll be going on a break shortly, and when we come back, we'll continue talking about anesthesia and delivery. Thank you.
And welcome to Clear on Health.
TSTV, connecting your world. TSTV, connecting.
Welcome back to our program, Clear on Health, on African Health Television. We've been talking about anesthesia and delivery. My name is Dr. Fumilayo Elusoji. With me in the studio is Dr. Ngulari. He's an anesthetic doctor. We've been talking about, pain relief for delivery and those that are available. So, sir, what type of anesthesias are used during the delivery process?
Basically, we have two major types of anesthesia.
Okay.
So, as I've told you earlier, from the definition of anesthesia that I gave you earlier was, it can be done while the patient is awake. It can be done when the patient is fully asleep. So basically, when we say patient is fully asleep, that's for surgery, not for labor.
Okay.
So for cesarean section, it can be done when the patient is awake. That's the one we call neuraxial block. Anything to do with the spinal cord. So it's neuraxial.
Okay.
And it helps take care of pain, total pain from the level of umbilicus, that's our area of target, down to the legs.
Yeah.
They become numb. Then under that one we have the common anesthesia women usually receive. That's spinal anesthesia.
Okay.
Then we have a more superior one to it, which is epidural anesthesia.
Okay.
Then caudal block, however, that one is hardly done. Then saddle will not help you because it's the same technique, the same procedure with spinal anesthesia, but saddle will take care of the perineal area.
Okay.
So that's it. So it's not so convenient.
Used.
Yeah. So
No.
it's not amenable to delivery.
No.
Yeah, as it is, because area of incision will go upper than where it blocks.
Okay.
Saddle,
Okay.
yeah.
Okay.
Saddle, basically, if you are dealing with the perineal area, it gives you a perfect
anesthesia.
yeah, anesthesia.
Okay.
So that's it. So basically, we dwell on spinal anesthesia and general anesthesia. In general anesthesia, we put the patient to sleep, total sleep, no pain, and temporary loss of memory. So we call it amnesia.
Wow.
So that the patient will not know what
What's
is happening, going on, because it could be traumatic. You are under anesthesia, especially if it is full general anesthesia, that the patient will go to sleep.
Okay.
We relax the muscles for optimal surgical condition. And if the patient is not asleep, it won't be so comfortable for the patient.
Okay.
So basically, general and neuraxia, which is local, more or
Those
less
are
local.
the major ones that are
Major ones
currently
that are
used.
commonly
I think I understand when people are scared to say they don't want to just be totally knocked out, because it's scary to know that you are not alert and certain things are happening. As human beings, we like to control everything that is happening around us.
Yeah, really. And to some extent, there is this type of anesthesia which is also a local anesthesia. We call it TAB block, transabdominal plane block.
Transabdominal
Yeah. So there's an angle at the lateral aspect of the abdomen.
Okay.
Where there's aponeurosis crossing, where muscles, we call it aponeurosis, that's crossing of the oblique muscle, internal oblique, and so there's a junction there where they cross, they formed an angle.
Okay.
So you now deliver your local anesthetic agent into that area. So it numbs, it blocks the nerves coming from behind.
Okay.
Yeah. So that one could supplement, but I don't think it could be amenable for, it would be suitable for total surgery, but it could supplement.
One of them.
It could supplement as well.
Okay. So those are the ones. Thank you so much,
These
sir,
are
for
the
that
common ones. Thank you.
explanation. So it's often believed that women should bear labor pain. In fact, I think there has been reference to, delivering like the Hebrew woman. They use that to say you are not supposed to
common
be.
language.
Yes, common language. So is the pain of labor more than the pain of episiotomy? Because people don't believe that you should, give an analgesia around where you're doing episiotomy. I think we should explain what episiotomy is. Episiotomy is a cut given by the physician, the doctor attending to you, or the midwife to enable the baby's head pass through the birth canal. I mean the what do you call it?
The perineal area.
The perineum area. Yes, to enable the baby's head pass through the perineum area. So that cut is given so that baby's head can easily pass through. So is the pain of labor more than that pain? Do you think women should have, analgesia?
Oh, basically from what we read, though experience is the best teacher, but what people say is there is no pain that you can consider like labor pain.
Yes.
There is no pain ever. They said is a very excruciating pain.
Yes.
Which is by scale is almost like 10 over 10, or maybe more than 10, if it can be extended.
Yeah.
So under normal circumstances, as an anesthetist, we don't want patient to suffer pain. That's the reason why we use so much drugs, like in multimodal analgesia. You use different drugs with different mode of action to abort pain totally. So that's it. So from we are advocates of no woman should experience pain. Just like in obstetrics, no woman should die of labor. So as an anesthetist, that's is one of our mottos.
Yes.
No woman should suffer
experience
pain. So that's it. But however, from what is going on, I think issue of, sorry, remind me what are we dealing with?
Okay, so we're talking about the episiotomy and labor pain.
So labor pain is far, 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 far beyond episiotomy. I think that's even the reason why people feel, okay, because that pain is more severe, you could just give episiotomy. Especially when the head is crowning, pushing against the perineal area, almost getting out of the vulva. So episiotomy is basically done when you now, as a practitioner, when you see that the perineal area is getting threatened to tear. So when you give episiotomy, you increase the size of the introitus so that the baby can come out. But if you don't give, you wouldn't be able to control the direction of tear, which may even extend medially and may even get down to the anus, of which repairing it is even more difficult because some people could even finally have incontinence if the tear is so bad. So that's the reason why we give episiotomy. Under normal circumstance, as an anesthetist, in that condition you give anesthesia before you give a cut. There is no room for you to cut somebody without giving anesthesia. Yeah. So, but I think it's a very crude practice. And so many of us learned from our teachers that it could just be given because the labor pain is more severe than. But under normal circumstances, it shouldn't be so.
Yes.
Even when repairing episiotomy, with my little experience when I was in gynae, you have to get a local spray of xylocaine. Spray it before you even inject xylocaine. But you know, all these things happen where things are working. Yeah. That's the norm. You have to spray so that it will numb the area. Then the next thing is you take your lidocaine, then infiltrate.
So that you don't even feel the pain of the needle going in.
Yeah, going in. So our target was to, minimize pain as much as possible. So this is our goal. So that pain is not a room because the pain is more severe, but most women still shout on the process of tearing them. They will tell you that you are giving them cut and so many other things.
So they're just not concentrating on that one. They are concentrating on the baby coming out.
Yeah, that's it. So under normal circumstance, you anesthetize the area and numb before you cut.
So that should be the practice.
That should be the ideal practice.
Standard ideal practice. So it's not normal for a woman to have a cut for baby's head to come out from the birth canal, like the perineal area and the vulva, without having something to numb the area and make her not have that much pain. Is not normal. So the reason why we are doing this program is because we want you to be enlightened and know certain things that are happening, especially as regards, delivery. So, sir, while we were talking about the types of anesthesia available, we talked about spinal anesthesia and epidural anesthesia, which are the common ones people hear about. So, sir, can you just briefly differentiate between the two of them?
Okay. Basically, when we say spinal anesthesia and epidural anesthesia, both of them, they are considered under neuraxial because they are being done on the spinal cord.
Spinal cord.
But when we say spinal cord, it's not into the spinal cord. It's just a literal language. Oh, it's just about the anatomy.
The anatomy.
In the anatomy of the spinal cord, before you get in, we have skin.
Yes, sir.
After the skin, we have subcutaneous tissue. After the subcutaneous tissue, we have the interspinous ligament, that's between the vertebral spine. Then, after the interspinal, finally we have something we call ligamentum flavum. So that's the toughest tissue before you get to those areas of the coverage of brain we call dura mater. So there is dura mater, there is arachnoid, then pia. So pia is the one that is attached to the brain, much inner, then followed by the arachnoid, then the dura. So when we say epidural, but they are all connected, especially at the level of the spinal cord. So when we say epidural, is around that dura.
Okay.
So you don't puncture the dura, you don't get to the level of the dura. The moment you exceed the toughest ligament that we call ligamentum flavum, there's a technique that we usually identify. There is low resistance. You can push air in freely with the low resistance syringe. So then by the time you could push air freely, so it means you are in the space. So you now, there's a catheter that will pass to enable you to deliver your drugs. That's epidural. EP around dura.
Okay.
But when we say spinal anesthesia, you pass all those layers, you now get to it means you have to puncture the dura, the arachnoid. That's the reason why we call it subarachnoid. So the space we usually target is after arachnoid.
Okay.
Because arachnoid and pia, they are matted, so you don't differentiate. And the other difference is once you get into in spinal anesthesia commonly, but to an anesthetist is subarachnoid block. There is a gush of CSF, that's cerebrospinal fluid. But in epidural, you have nothing to do with fluid.
Okay.
So to some extent, spinal anesthesia is more invasive than epidural. Yeah. So, and however, when it comes to analgesia, as much as we can give in labor, not even for cesarean section or delivery, in as much as you can give low dose spinal, just give low dose, but instead of using maybe 2 mils, you could use maybe 0.5, at most 1 mil. We give a very good and excellent analgesia.
Okay.
Yeah. So it's the same thing can be used for cesarean section for delivery. Epidural can be used for cesarean section for delivery as well.
Okay.
So that's it.
So thank you, sir, for that differentiation. So we see that the epidural anesthesia gets to before the dura mater, which is one of the coverings of the spinal cord. Now the spinal anesthesia gets beyond the arachnoid. Okay. So thank you, sir, for that explanation.
You're welcome.
So viewers, we'll be going on a break shortly, and when we come back, we'll keep talking about anesthesia and delivery. Thank you.
Welcome to Clear on Health.
TSTV, connecting your world.
Welcome back to our program, Clear on Health on African Health Television. My name is Dr. Fumilayo Elusoji. With me in the studio is Dr. Ngulari. He's an anesthetic doctor. We've been talking about anesthesia and delivery. So before we went on the break, we started talking about epidural anesthesia and spinal anesthesia. We tried to differentiate them, and explain what both of them were about. So, sir, who are the people that qualify for epidural anesthesia?
Oh, when it comes to qualification, who is supposed to collect epidural? Any obstetric patient is supposed to have epidural, unless if there are some anatomical problems.
Okay.
Because every neuraxial technique procedure you are doing, there are some factors that we have to rule out before we give.
Yes, sir.
If a patient has spine abnormality or spine problem, you don't venture in, because the next thing, if you venture, she will say you worsen her back problem, you worsen her problem. And of which she will have gone into her labor, suffer her pain. She would prefer that one to your intervention. Then you are adding insult to injury. Then any woman with, just like the normal contraindications to spinal anesthesia, when there are sore or injuries or sepsis at any kind of injury or infection around where you intend to go in, you don't do that.
Okay.
Then any patient who says she doesn't want the procedure, you have to respect patient's right.
Yeah.
So, but in a healthy obstetric patient, every woman is supposed to have a pain-free labor.
Yes.
So indirectly, she qualifies to receive epidural.
Yes, sir. Thank you so much for that, explanation.
You're welcome.
So in our prior discussion, you said epidural and spinal anesthesia can be given both in normal delivery and cesarean sections. So when in normal delivery do we give epidural anesthesia?
In normal delivery, normally in obstetrics, there is something we call, that's the phases of labor. The early part and the later part.
Yes, sir.
The what differentiates the early part is the progress that the cervical dilatation, the womb dilating to 4 centimeters. So that's the early phase. So then after the early phase, you now move to the active phase of labor. So that active phase of labor starts from 4 centimeters. So it means it's an established labor, because in those women that have given birth several times, on a normal day, dilatation could even get to 3 centimeters. If you give epidural that time, indirectly you have not achieved much. So in an established labor, so indirectly that's from that 4 centimeters.
4 centimeter cervical dilatation. That's when it's a normal time to give. So how common is the practice of epidural anesthesia in Nigeria as a way to prevent pain during labor? How common is it?
Oh, as far as I'm concerned, it's not so common, because I know I've worked in several centers. It will take like a month or 2, nobody requested. So indirectly it's not common.
Yes,
so
sir.
it's even better in Abuja, which is the capital of
territory.
So enlightenment is better in Abuja. People are more economically better, awareness and so many other things.
Okay.
But even in Abuja, it's still far
less than
what is supposed to be obtainable.
So in a month, how many patients from your experience would request for epidural anesthesia?
In fact,
in a month,
especially where I practice, may not be more than 5.
Okay.
So and you may see women coming to deliver probably up to 100 or so.
Yes.
Then the ones that will request may not be more than 5.
5. Wow.
So which is very, very less.
Very less.
Mm.
Okay, sir. Thank you so much for that.
You're welcome.
So what about the complications? Because there are certain words on the street about epidural anesthesia or spinal anesthesia. I saw somewhere online where somebody put on Twitter about having back pain several months after having epidural anesthesia for normal delivery. And then there was another lady that corresponded that same, report. So that is putting fear, because we're trying to create awareness that labor can be painless, and then someone goes through the experience and is saying, don't try epidural anesthesia, it will give you back pain. So sir, what are some of the complications? Let's talk about the back pain complication for epidural anesthesia.
Basically, back pain, when it comes to spinal and epidural anesthesia or analgesia, whichever. Let me start with spinal anesthesia. In spinal anesthesia, the needle we use, in the olden days, people use a bigger needle. But presently, we use a very tiny needle. We use a size 26, 27. And the normal injection needle is around 19, 21. So, and the higher the number, the smaller the size. So what we use is around 26, 27, which is much, much smaller than the normal injection needle. So if you look at it, it won't cause much trauma. And with advancement in anesthesia, the nature of the needle we use, which is a pencil pointed, not the cutting edge, the one that will create injury on the dura for continuous CSF leak. We hardly, we don't think it will give that pain that people are afraid of. However, some pain is just attributed to that. But it could be maybe from carrying that pregnancy, the changing in lordosis, the architectural curvature of her hair. So probably that alteration, by the time after the patient now delivers, you now want to resume your normal architecture, which now gives pain, probably. But spinal needle, from our point of view, or from anesthetic point of view, may not be able to give the kind of back pain people are complaining of. Then, when it comes to epidural anesthesia or analgesia, the needle is slightly bigger. We use size, it's slightly bigger than the spinal. Then, even at that, we don't envisage that kind of pain people are complaining of. However, there is no procedure that doesn't have complication. By the time we said epidural is supposed to be outside dura, mistakenly, technique, if there is inadvertent or mistakenly punctured the dura because of the size, patient can have temporary headache and back pain. Of which they are common, it could happen. Depending on the circumstance, depending on the person's technique, and so many other things. But still, the advantage is better than the not having it.
Yes. So the advantage, I see you're advocating for.
We are.
Okay, sir. Thank you so much for that explanation. So that means there's an aspect of, the technical aspect of the person giving.
The person giving.
Yes, but it still should not discourage people
from
having.
At all, because those puncture, number of duras that are punctured, they are minimal compared to those that will have it successfully. So every woman should believe that she's part of those people that will have a successful one.
Yes, every woman should believe that she's part of the people that can have a successive epidural anesthesia if she wants to have it for normal delivery. So, sir, apart from back pain, what other complications can we have from epidural anesthesia?
So, every procedure has complications, as we have said. Some of them could be scary because, okay, fine, but we could manage it. Depending on the concentration of the drug you give, especially in anesthesia, but analgesia, there is no problem. That's the one we call walking epidural. However, to some extent, we don't advocate them to keep moving. but they could still move. The motor will still be there. They can move, but we discourage. It's better let them stay in one place.
One place, okay.
Yeah. So basically, that complication can just come up like hypotension if it is in anesthesia, because the concentration of the drug you give is higher than analgesia. If you are giving analgesia, it's the same drug, but you dilute. You give a low concentration. Okay. So which may not give you that hypotension. But even the hypotension is temporary. Okay. And if we notice and we feel it's life-threatening to the patient, we give drug that will counter it.
Okay. So I think we should even talk about, let's say, when we say hypotension, because...
Okay, low blood pressure. So that because, are aware of what we mean. You know, the problem is I'm talking to somebody who is medically... Yes, sir. So, because the drug works on the nerve of the spinal cord. Okay. And those nerves are the ones working on the vessel. Yes. So by the time it gets to that nerve, and the nerve is anesthetized, so there is a vasodilatation. The vessels will dilate and blood pressure will come down. Okay. So, but it's not life-threatening. Yes. Because we monitor and we expect it could happen. So once we notice, we give drug that will counter that effect. And patient does very well. Okay. So, apart from hypotension, back pain, other kind of complications can happen? Other kind of complications could happen, but they are by the way, so that it doesn't discourage our viewers. Dr. Onglai doesn't want to discourage anybody from having epidural anesthesia. Thank you so much. Because once you are in the hand of a qualified person, you don't have any fear. Yes. Thank you, sir, for that explanation. Thank you. So, viewers, we'll be going on a break shortly, and when we come back, we'll keep talking about epidural anesthesia and any other different other anesthesial topics. Thank you.
Skit Chat, right here on Bright Television, the home of talk and entertainment. Skit Chat.
That's crazy. Do you know I don't know him?
Are you normal?
I don't have an idea what he's saying.
Do I know you? Why are you talking to me?
Wait a minute.
Jesus!
Skit Chat.
He said your stepmother put poison in the food.
Baby! What is it? What kind of nonsense with this now? What you rubbish? This is wrong.
Skit Chat.
I came to you in confidence.
Do you want the whole world to know you're coming to pick me?
That's why you do.
Babe, what kind of stupid driver is this?
You there, okay? Check now, this time for you. Have you not open your eyes? That you are sliding. If you not, the sun will back up like that. Why check out everything? Now you are you mad? I mean,
You are going for hook up. Oh yes. Don't worry. I will shave my beard for you.
Skit Chat, right here on Bright Television, the home of talk and entertainment. Don't forget, you can also watch us on TSTV Africa, channel 102, Bright Television. Skit Chat, we celebrate creativity.
Welcome to Clear on Health.
TSTV, connecting your world.
Welcome back to our program, Clear on Health, on African Health Television on TSTV. My name is Dr. Fumilayo Lusoji. With me in the studio is Dr. Ngulari. He's an anesthetic doctor. We've been talking about anesthesia and delivery. So before we went on the break, we started talking about epidural anesthesia, and we started talking about a few of the complications. So, sir, while you were talking, I heard you mention epidural analgesia, epidural anesthesia. I want us to briefly differentiate between the two so that people understand what they both stand for and where they can be used.
Okay, thank you very much.
Yes, sir.
Oh, when we say epidural anesthesia and analgesia, it's more or less the same thing. However, the difference is just the concentration of the drug that you administer into that patient.
Okay.
Oh, normally the drug comes in a concentration of 0.5 milligram. So when you are dealing with analgesia, as I've told you earlier, analgesia is supposed to be just relieving pain. Not abolishing totally, not abolishing the pain totally, relieving.
Relief pain, okay.
So in anesthesia, we expect total pain. That's the reason why we are using a high concentration.
Okay.
So the only difference is the same technique, you get to that epidural space. However, when it comes to delivering drug, you use a lower concentration for analgesia.
Okay.
So, and you don't expect total weakness of the limbs.
Okay.
Yeah, that's the reason some people call working anesthesia, working analgesia,
Okay.
working epidural.
Okay.
So that's it. But by the time you use a higher concentration, it affects both the sensation and motor. It makes the limb numb and weak.
I think we should talk about what motor sensation is, because
Okay.
when we say motor, we understand.
Yeah, when we say motor, indirectly, even the limbs wouldn't be able to move the limbs totally.
Yes, yes.
So it has affected the nerve supplying the muscles
yeah.
temporarily. But when we say just analgesia, the patient will even still be able to move limbs.
Okay.
Though we discourage to walk around because
around.
we don't know the intensity of weakness that you have.
Yes.
So that's the only two differences.
Okay. So, sir, analgesia, which is used for normal delivery? Epidural analgesia or epidural anesthesia? Which of them is used
for normal delivery is analgesia.
Okay.
However, after you have sited your epidural catheter in and everything, if coincidentally the patient is not able to deliver,
yes,
you convert it to anesthesia and still use the same thing. There is nothing like puncturing the patient again. You just increase the dose, deliver. That's all.
Okay.
So just that's the difference.
I think what people should know is that epidural anesthesia leaves a catheter.
Yes, and there's a catheter,
Yes.
a very tiny rubber.
Yes, something
By the
at
time the
back.
needle gets there, we now thread in that rubber, the catheter, and leave it permanently placed or temporarily placed.
Yes.
So indirectly, the beauty of epidural is, if unfortunate, the patient is not able to deliver, it now becomes a cesarean section. We could just leave that catheter inside and continue topping for almost 2-3 days. Totally, you don't have to be receiving injections for analgesia.
Yes.
So through that route, can just solve your pain problem throughout your postoperative state.
So analgesia, epidural analgesia is used for normal delivery.
For normal delivery.
The dosage of the drug that they are going to
That's
be
what
getting
matters.
is reduced.
It's reduced.
Then for anesthesia, epidural anesthesia,
The
we're
dose
talking
is
about
higher, a higher dose.
So for like a cesarean section, that's the case that we use.
That's the case we use.
Yes, sir. I know we've already talked about certain complications of epidural anesthesia, but I've heard people talk about paralysis. It's word on the streets. But I want us to go from the medical angle, the technical know-how. Is it possible to get paralyzed after having epidural anesthesia or, spinal anesthesia? Is it possible?
From our anesthetic knowledge, it's not possible because you have not injured any nerve.
Okay.
You have not injured any nerve that could give paralysis.
Okay.
Worst of it, if you coincidentally even, there's a level where we give TOR, of which the spinal cord is higher up, is a potential empty space, so you don't injure any nerve.
Okay.
So paralysis and spinal anesthesia or epidural is not common if it is done by the person that is supposed to do it.
Yes.
But if it is somebody who doesn't know the anatomy, anything can happen.
Anything can happen.
But normal, ideal technique or ideal procedure done by a trained anesthetist is not possible.
Not possible.
Paralysis, no.
Yes. Thank you so much for that explanation.
Thank you
One of the things about good medical practice is that it is holistic. So what that means is that we'll take a good history. Because if you recall when we're talking about, people that we won't give epidural anesthesia to, we talked about certain, spinal deformities. So we'll take a history, we want to know some family history, we want to know prior history, medical history, and then we'll do our examination.
Yes.
We ask a lot of questions, and then before we decide, okay, this person is fit for this procedure. So what this means is that you need someone that is a specialist to do certain procedures. You can't just go with what's on the streets or what has happened to this person. That someone can deliver a child does not mean they can give you certain kind of anesthesia to reduce pain during delivery. So this information is so that you don't make certain mistakes. You don't assume that a doctor is a doctor of everything. Yes. Okay, sir. So, sir, I want us to talk about the reason why do we give epidural anesthesia or spinal anesthesia, epidural analgesia and spinal analgesia during normal delivery? Why don't we give the others? Because I know we talked about, total intravenous anesthesia, general anesthesia. We talked about saddle block. Why is it specific for normal delivery? Why do we give epidural analgesia or spinal analgesia during normal delivery and we don't give the others?
Fine. In as much as in obstetrics, we prefer a technique that patient will be conscious.
Okay.
You can't give general anesthesia to put the patient to sleep when you want the patient to deliver. And there's a point you tell the patient to push. If the patient is asleep under anesthesia, the patient wouldn't be able to do that. The patient wouldn't listen to you. So most of the procedures we give to a parturient, woman giving birth, in as much as possible, obstetrics, give a technique that she will be conscious, she can obey your command, she can even assist you in the process.
Yes.
So, however, we have, I didn't mention because they are not common, so I was just restricted between epidural and spinal.
Yes.
We could also give caudal block, saddle block, but I told you those, especially caudal could help, but it's not so common, and if A can give better and satisfying condition, why giving B?
Yes.
So that's it. So both of them, they are epidural. Caudal and the lumbar, they are epidural anesthesia or analgesia. We could give. We best give that caudal in pediatrics, especially when they have a surgery. Anything below umbilicus, it gives perfect analgesia postoperatively. So that one basically is most for children. It can be done in adults, but
majorly for children.
Lumbar one is more applicable to them. Then, in as much as we said, give anything intravenous. I told you initially, opioid can be given in labor. But some people are scared, maybe respiratory depression for a child. Before that child will be delivered, unless if it is a precipitated labor. And I think most of the conditions is just people are scared. But especially anesthetists, we appreciate and we are very confident of our opioids. We use them liberally. And we don't envisage any condition.
Yes, sir. Thank you so much for that explanation.
You're welcome.
So, sir, what are your last words? Because we are advocating for people to have, access to these things are available, so have access to them. We're advocating for easier labor, painless labor, yes, and other procedures that can be done. So, what are your last words to viewers watching
Okay, my take home to our viewers is we encourage them as much as possible.
Yes.
Learned or even those that are not well educated, they
Yes.
should know that something like this is obtainable. If you go for any antenatal care, ask for what is epidural. How can I have, if you can't remember the name, how can I have painless delivery?
Yeah.
And they should link you to an anesthetist who can explain it better. Who can explain it better, and you will be satisfied and you may be convinced.
Yes.
So, but we advocate no woman should go through the kind of pain that people explain as labor pain.
Yes.
Because we advocate of no pain.
No pain.
Yeah,
Yes.
so that's my take home.
Thank
and
you
we
so
encourage it is accessible
Yeah.
and affordable.
Yes. Thank you so much for that
Thank you so much.
explanation and your time.
Thank you
So dear viewers, we've been talking about anesthesia and delivery. We've talked about the different types of anesthesia. We've talked about the ones that are available for you to use during normal delivery. We even went on to differentiate between analgesia and anesthesia and where they can be used. With me in the studio is Dr. Ngulari. He has been educating us and informing us about all we need to know about anesthesia and normal delivery. My name is Dr. Fumilayo Elusoji. Till next time when we come on Clear on Health and talk about other health issues. Thank you so much for joining us.
You're welcome.
Bye.
And welcome to Clear on Health.
TSTV, connecting